think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
Grant.
And
so that's quite a trick.
That gets us into how we do our work, right? How we try and do our case analysis. So one way to do that is through the package we built. So we build a package. You know, some people are just doing like one and done projects, so they do one DBQ and one Nexus and call it a day. But if you do a holistic whole body analysis, a lot of these different codes will cross and interact, and you'll get a more comprehensive look at it. So we do a DBQ for all the different organ systems, and then we do a Nexus for all the systems, and we do these lay letters, right? The lay letters to give you another look at it, what you're talking about there, right, Bill?
Yes. It's so important, and a lot of people were taught to follow the documentation rather than follow the evidence. The law and the regulations are clear. VA must consider, when making a decision, must consider all the medical and all the lay evidence. It's not limited to what's documented. And so, one of the things, we can relate this back to herbicide exposures. I was assigned for a while to handle the Niemer cases at the office. And people were bringing cases to me and say, well, he said he went ashore, but it's not documented. Let me see what he said, okay? And if you have enough experience, enough knowledge of the circumstances, place, types of service, you can make a pretty fair guess without speculating, really. It's just, is it likely as not? Is it more or less likely? And you can do that because you can understand the circumstances that person experienced at that time and make a judgment about, does that sound reasonable? Like the Army cook who said he flew food up to Quezon and was shot down there, and he had to stay there during the Battle of Quezon. Oh, really? Well, I can just look at his DD-214 and see that he arrived in Vietnam the year after the Army returned Quezon back to the enemy. Okay. But then you have the opposite circumstance where someone says he was sent aboard the aircraft carrier at Yankee Station and that his plane landed at Da Nang and he transferred over to a hop and flew out to the carrier. So he set foot in Vietnam. Okay. Well, he had been denied. I think by the time it got to me, it had been in the system for like 10 years, okay, on the basis that there's no documentation saying he set foot in Vietnam. Okay, I don't need documentation. What he said was, and that's evidence, his sworn statement was he set foot in Vietnam and took a hop out to the carrier, okay? Is that consistent with circumstance, place, and type of service? Yes, it is. Because those ships were either serviced at Yankee Station either from Manila or Da Nang. Guess which is a lot closer, okay? But I know from historical context and seeing so many official documents that did place an individual at Da Nang and taking a hop to the carrier, okay? I saw so much of that over my career that I know that that's consistent with many service members who joined a ship after it already sailed. Of course, I also knew that in 1966, we did not have an aircraft capable of taking off from California and landing on an aircraft carrier deck in the South China Sea. Okay, so it's that kind of insight that makes a difference, and that's why that lay evidence can be crucial.
So, Bill, what I do a lot of times when I do my DBQs, I do the same kind of thing. Like, well, the spine, we're talking about those sections where it says radiculopathies, where it says other types of symptoms. So those boxes that allow me to write in there instead of just check the squares, how does the rater deal with those? Is that helpful? Because I could say you might have, bowel and bladder dysfunction or ED, and that kind of stuff expands the DBQ and takes it out of the automation maybe, right?
Right. That's why our process, the methods we're using, are so helpful to both parties, VA and the veteran. Because if you take a one-and-done approach on the spine and you give a spine DBQ, it gets to the rater does not have any evidence of radiculopathy that may be separately compensable. Well, let's see. Am I going to? I've got to produce. I've got to make these decisions 4 times a day. Okay, and I don't get credit if I defer it. Am I going to defer it and say, yeah, okay, thanks for that, but we need another exam because we got to figure out the radiculopathies, and then it'll go back through the system all over again, and it'll get rated when that evidence of radiculopathies has been clarified. Or, with our approach, we know that we have to evaluate those complications. So we'll give a stack of DBQs all at once on all of the conditions that are related to the primary condition. That way, when it hits the rater's desk, the rater is able to say, okay, I've got every manifestation I need to evaluate every complication of that disc. Here's your check, because he's under pressure to get it done fast and now. And the temptation is to accept a less than fully complete exam so he can get the point and not develop for the radiculopathy. So you can run into that. In fact, oh my God, I just reviewed a case this week from 2009 where that very thing happened. They did not fully develop for all complications of that veteran's spine disease. Now, as a result, they gave him a subsequent exam, and they assigned some radiculopathies. And guess what effective date they used? The exam date that established the radiculopathies. No. The veteran wrote on his original claim in 2009 that I have back trouble and leg trouble. Okay? It wasn't until 2013 that VA finally got around to realizing, since the Board of Veterans Appeals ordered them to do it on remand, that they have to give him a neuro exam to evaluate the radiculopathies. Once they did that, then they had the evidence that shows, oh yeah, the legs are not it's not a problem with the legs. The legs are okay. It's a problem with the nerves from the sciatic nerve branch that's causing it. And so the effective date should not be the date of exam. It should be the date of claim back in 2009. We're going to try to get that for them. So that remember I mentioned before that when I was representing claims, they tend to go a little faster, a little better. And that's why, because I know what the rater needs, and I satisfy the rater's needs. And so cases I represented were done quicker and better because it was very much in the rater's interest to do so. The way we do it, try to get it all covered to start with.
So some of the places now are, I guess, trying to be sort of dissuaded from doing examinations. Like you said, the rater comes across his desk and might need 2 or 3 different sort of DBQs for spine or for TBI. And in the old days, they might have sent them out to do that, but now to try and be speedy, they might just overlook that aspect and go forward with an incomplete workup for secondaries, right?
Yes, and if the let me just discuss evaluating orthopedic disabilities as an example. Okay, now the court has been asked to review BVA decisions about evaluating joints like knees and elbows. Okay, many times, and they come out with decisions and they say, okay, well, VA, you have to consider this or you have to do that, and that's a new lawful precedent because no court has ever said that before, and so now the lawful precedent, for example, in DeLuca, you might remember that from 1995. DeLuca was saying that it's not enough just to measure how far the joint bends. You must consider other factors such as pain, endurance, speed of motion, in coordination. Okay, so 15 years later, 2010, I'm now a decision review officer, and VA is offering up some updated training on orthopedics. And what do? They teach, okay, DeLuca says, and this is a precedent now. Well, if you really read what DeLuca said, the only thing DeLuca said was, VA, you have regulations. You must make a decision that is in accordance with your regulations. And your regulations require you to consider all of these factors: pain, limited motion, functional loss, in coordination, all those sorts of things. And so that's what DeLuca said. And so they don't understand that, okay, yeah, it's a new legal precedent. However, it was law prior to that because it was in your regulations at the time. Those regulations have been in place since 1933. Okay? So what happens is this. The DBQ prompts the examiner, and it says, okay, is there additional loss on use or during flare-up? Okay? And 99.9% of the time, what does the VA examiner say? He checks yes. No. Many times he says no. But for those who check yes, there is additional loss during a flare-up or on use. The next thing is, how many degrees of motion do they lose during a flare-up or on use? And the answer is, well, I don't know. He's not having one, so I can't observe it. And they've done that. They're still doing it that way. Okay, so as a rater, I can't fill in the blank. I'm not permitted to say, okay, the examiner says it's going to be worse, but I don't know if that shoulder pain is going to limit him to 45 degrees or to 90 degrees. I don't know. So I don't know whether or not to give him the higher evaluation based on use or during flare-ups. That problem has not been solved. It hasn't. Now, what I would do, and what I encourage other raters to do, is this. You look through the record, you find examinations. Some of them show more limitation than others. Okay? Well, if one of those examiners is saying, yes, the patient is having a flare-up, then that shortened motion is obviously, to me, represents what it's like during a flare-up. So I use the higher one. And so that's the key.
What I'll do, Bill, what I'll do oftentimes in my DBQ, say for the spine, if the patient has a flare, I'll just write out in the boxes, flare up, pain at rest, and put zeros, stuff like that, so you can explain the flare up and why the range of motion is so low.
Being specific, yes. Being specific.
So Bill, I'm just looking at DBQ for TBI, for example, and they're saying, which is actually the internal one for the VA. And they've got a section on there that talks about, it says check these different things, motor dysfunction, also complete joint spine DBQ. Hearing loss, please complete tinnitus DBQ. Seizures, please complete seizure disorder DBQ. So that's the way all these things should be done when you have the different sort of organ system problems within the spine or the brain. You should have all these accessory DBQs, right?
Exactly. And it's prompted to do that. The system has the prompts to get the examiners to do that and to get the raters to ask for it. Same thing with diabetes. You have a gen med that gives you the diagnosis, identifies the complications, and then you get the specialists doing all the specialty exams for all the complications. And oh, by the way, we could expect more than a few thousand of those coming in once HR 299 is implemented by VA and we start getting these, let's call them the 12-mile blue water veterans. There's going to be thousands of claims that need to be done over now based on that law change. We might recall that Procipio v. Wilkie was decided in the Fed Circuit last January 20th, 2019. And as a matter of interpretation of law, the court said 12 miles. 12 miles. But in the interim, Congress enacted and the President signed into law H.R. 299, now Public Law 11623, signed on June 25th. And so now the law is you're presumed exposed if you went within that 12-mile limit of shore. And, that's going to eliminate all that debate we used to have about whether or not one bay versus another bay was covered or not covered. There was a case in the court a few years back called Gray, and the problem was that the VA could not explain to the court why they would rule one bay in and another bay out. And of course, Da Nang was a very big bay with a lot of people, and of course that was ruled out. Okay, so VA couldn't explain to the court why one bay would be in and one bay would be out. And so HR 299 eliminates that. And it's now 12 miles. So basically all the bays are going to be included. The VA is going to have to re-adjudicate all of those claims that was over the flight of the bays. And then all of these diabetes claims are going to come forward. And they're going to need these multiple DBQs for identifying and evaluating all these complications of diabetes. So there's going to be a lot of work next year.
Hey, Bill, can you, the last couple of minutes, this idea of probative weight, I try to explain to the veterans that we want to have the lay letter be consistent with the DBQ, to be consistent with the nexus letter, to be consistent with the testing.
Sure.
So if all that stuff lines up and one examiner says that they have, normal range of motion and the x-rays are positive and the patient says he has swelling, you can't get out of bed. And, how do you weight that? Do you try and look for consistency, or how do you?
Consistency is a factor. When the veteran says, "Okay, I'm this disabled, I can't do these things," but then in the treatment records it says patient's well, system's normal. Okay.
Right.
It sounds like on the claim form that, and what he's telling the VA examiner is, my golly, how could this guy bear to live? It's just so bad, so much pain, he can't move. Oh, golly, he can't do anything. All right.
DBQs.
Then you look in the treatment records, private or VA, and you see that, there was a strained his shoulder last week playing volleyball. Okay. So that's kind of an inconsistency. So now you've got to retreat more to what you can actually assess objectively instead of as subjectively.
Which might be the DBQ, might be the...
Yeah, now a DBQ could be done on a good day or it could be done on a bad day, okay? And we've got to look to the record in general to see which it more likely represents and grant the higher whenever possible. Now, they don't teach this. They don't teach this to new raters coming in. And so being able to understand why if one examiner says the shoulder goes to 45 degrees and somebody else says it goes to 110 degrees, why the difference? Okay, well,
like in my nexus, I'll try and referee that. I'll say the exam says this, the x-ray says that, Dr. Jones said this, it was different, the patient says that, and try and referee.
Exactly. You point to those events in the record that support your conclusion. That makes your opinion tight. It would, particularly if I've got somebody who's an MD, explains the medicine to me, explains the evidence that points to it, and then I've got a VA examiner that's a nurse practitioner or physician assistant who says, it is because I say so. Okay, I'm going with the private doc. All right. Boy, we covered a lot of ground.
Yeah, we have.
I hope somebody benefits.
Bill, how much did the BA give you to run you off?
Now, decision to retire is never just one thing. It was sometimes frustrating to, the pressure to do many cases, and that was more important than applying all the knowledge and the depth of understanding that I have. That was a source of frustration.
Bill, just don't say I bribed you to leave.
Yeah.
Yeah. But then, I had real bad ankle pain, and I decided to get a new ankle, and it just all kind of fell apart at the same time.
Yeah, that's easy to do. But
Bill and I worked together. We started in '96, right, Bill?
Yeah. Yeah, '96.
Back in the day.
Well, you made a good team, and by golly, I hope you keep doing good for veterans. That's for sure.
I certainly hope so too, and I sure glad to be here and be able to share.
Dr. Bash or Bill, you guys want to give out your information here?
Yep. Dr. Bash, Google Dr. Craig Bash or Veterans Med Advisor, or call Skip. My schedule guy is 925-381-7561. Skip again, 925-381-7561. Bill kind of has access to people through me, but we work together as a team, and then Bill could talk to people, and away we go.
Yeah, Doc and Skip, they select which cases they want me to review.
Well, that's good. And it's good that we have a team out here that is working together and helping veterans. And that's always important, because a lay veteran, a new veteran coming along starting out, I don't see how they're going to do it without some proper help.
Yeah, it's David and Goliath. VA has a 400,000 person team.
Oh, yeah, boy.
Right? 400,000 employees, whatever it is.
That's so true, and they know every trick in the book, and you have to know them just as well to deal with them.
And you got to hang in a long time.
Updates.
Keep your back straight. Yeah. Keeping your back straight, because they'll scramble your brains if they can.
Yep. it's like Bill says, don't give up because it's kind of a marathon. You have to do quite a few iterations. That's right.
Yeah, I've seen a lot of them give up. But
and I tell you what else is sad. I'm sad to say it, but I've seen a lot of them die.
Yeah, that is a shame.
Always. That's a hard reality that you have to live with in this business, and you're trying to help folks. And
well, at least now, Bill, the spouse can carry on with the claim if they'll do it.
Yeah.
That is.
If you have a spouse.
Yes, that's not much of a consolation, but it is better than nothing. Used to, the claim died with the veteran. That was a crying shame there.
Yeah, that was a shame.
I have a couple of them I've written medical opinions that said this guy's going to die like in 2 weeks, from my medical judgment, and they still passed before we got it done. It's unbelievable.
Man.
Oh. Well, nobody wants that diagnosis. Everybody wants to go to heaven, but no one wants to die.
That's something that, from a medical standpoint, it's really nice because we can, the rating and there's monetary things, but it has a big impact on people's care because you get the right diagnosis and you get the right treatment in the hospital, and you get better care. It can make a big difference in longevity. Thank you all for listening. That ends this show, and now I'm going to zoom off.